Here you go.
There's
Now it's recording. Can you see the button that it's recording?
Yes.
Okay, what I'm going to do now is I'm going to make you the host.
Okay.
Where are you, Manuel Persona? And then I'm going to I'm going to put something into the chat. Won't let me do that right now. I'll put something into the chat. And I will stay on email for a few more minutes to make sure that everything works. So if there is a disaster, email me. And so, you know, if you're the host, you can actually mute people's microphones. So if there are dogs barking in the background, I actually go in and I mute that person's microphone. You can ask them to unmute. So let's see. So I'm going to leave, make Manuel the host, and I'm going to be available on email for the next 5 or 10 minutes before I get my.
Okay.
Thank you for doing this, man.
So we will not have dogs and kids.
No barking dogs. That's a familiar pub here in the United States. Often you'll go into towns and have a barking dog pub or something like this for your beer. And I think Maritza is on. If you want to.
Yes.
Oh, there you are. Okay. Yeah,
I'm here.
Oh, thank you very much for your slides.
Hi, how are you?
Good. Thank you for joining us.
Thank you very much.
Arrianne will go first. Arrianne will go first, and then we'll have you follow up with her from her.
Who is responsible for the slides?
Perdón, aquí yo que le cobraron 66. Usted le cobra el examen 199, ¿cierto? Sí. ¿Y a usted le cuesta cuánto es? No, esto es lo que yo pago. Y lo que a mí me, por ejemplo, 199, yo le cobro a este señor 480. Ya dése cuenta. Entonces, nosotros lo que vamos a hacer, lo que tendría que hacer es, en todo caso, para que el cliente salga satisfecho, tendríamos que ponerle por 180 como reembolso.
Claudia's on. Ramaya's there. Hello.
Hello.
Maria Costa, I think. Yes.
Yes.
Hey. Hello. Thank you for joining us. That's a great background you have there, Maria. I don't know. Where is that?
Cartagena, Colombia.
Ah, beautiful.
A place where I would love to be today.
Yeah. Well, it was pretty warm here in
Yeah,
Maryland.
it is. Here it's also very warm today.
Yeah. I think Louis just joined us. And Mario.
Steve, are you going to run the slides or each speaker one minute?
Hopefully, Maritza, can you run the slides? If we transfer share the screen to you, can you get the slides up okay?
Yes, I can get the slides. It's not a problem.
Okay, great. Thank you.
Thank you very much.
I'm not sure if, oh, there's
Welcome, Eliecer.
Hi, Eliecer.
Saludos cordiales a todos, un placer.
Saludos.
Saludos. From Roma.
Can we start? We are waiting for some others.
Waiting for Arrianne.
Oh, Arrianne.
She's going to lead
Hello,
us off.
everyone. This is Luis from Colombia.
Luis.
We don't know you.
Neither do I.
How many countries are participating?
Well, there will be just the two major countries tonight. Will be Ecuador and Chile. We've been running two countries per week when we have the sessions. We try to feature them and give them each about 30 minutes. Both the patient representative and the clinician and researcher representative from both countries. And it's certainly not, we would love to have more time, that we could have more people present, but we're going to have some opportunities coming up later on with the work groups as we form them. There's Milton. Hello.
Hello.
And we're waiting for Arrianne, or are you going to make the presentation for her? You're not making her presentation, are you? And Eliecer, thank you for giving both the Spanish and the English translation of the slides. That worked out very well. Oops. There, now you're unmuted.
Maritza, ¿estás atenta?
Yes, Marisa, we have both Marisa.
Acá estoy. Welcome, Dr. Milton.
Hello. Hello, everybody.
Hello.
How are you?
Hello.
No.
Are we waiting for Arrianne?
Waiting for Arrianne. Milton, you don't know if she's not coming by any chance, do you?
I think she was coming because she was the one that invited us. So
That was what I thought too. Shall we get started, and then we can always revert back to Arrianne when she comes here, and we can start with the patient perspective, if that's okay. Does that sound all right to everyone?
I think Ariane is just here, just got here.
Is she here now?
Yes. I thought it was 5:30. I was thinking about, I have time.
Okay. Do you want to go ahead and do a brief introduction of yourself and then get started? Manuel's running the slides tonight, so he'll share the screen with you. Is that okay?
That's okay. But,
so, Arrianne, go ahead and start, and then we'll get your perspective. Then we'll move to the patient's perspective for Ecuador.
We are waiting for Ariane.
She just joined us.
Is there any person who are going to pass the slides?
Yes, Manuel Posada.
Okay.
He's trying to do it. Yeah, just a few minutes, few seconds.
I didn't see the slide of Arrianne because I have legislation. Eliecer. I don't have the. When do you send the Arrianne? When did you send Did you send the slides today or
No,
yesterday?
No, on Friday, last Saturday.
Last Saturday. Manuel, if you can share the screen with me, I think I can bring them up.
Okay, you have, because I have all, but not from the Arrianne.
Okay. Let's see if I can find Arrianne.
Yeah, we can see Steve.
Okay.
That's fine.
1 second. Okay, and
yeah.
Arrianne, I may have to move the screens forward if you like, if you're not able to.
Okay.
Okay.
Well, first of all, I apologize because my delay, but at the same time, I wish to thank the organizers and the rest of participants for the opportunity to express my opinion regarding some aspects from my point of view related to rare disease in Ecuador. I would like to say that this phrase means or resumes what Ecuador means, 4 words in one place. To begin, I would like to, the next slides, please. I would like to show some general data about Ecuador. Ecuador is a country located in South America on the Pacific coast and is bordering by Colombia and Peru. Has a population of about 16 and 17 million inhabitants. The currency is the US dollar, and the language, official language, is Spanish, but also there are some others official languages, such as Quisoe and Shuar. Ecuador is divided in 24 provinces, but the most practical, I think, division is in 4 regions that means Amazonia, the coast, this is the beach, the Sierra or the mountain, and the insular region regarding to Galapagos. The capital of Ecuador is Quito, and the health system are combined because there is public health system and private health system. Next slides. But one important thing I consider in this topic regarding rare disease is that Ecuador is a multicultural and multi-ethnic country. There are 14 nationalities and 18 indigenous communities that coexist. And I think this is an important situations similar to many other countries from South America, because in the indigenous community, there are some weight of relationship between them that I think reveals at least two important variables related with rare disease, such as endogamy and consanguinity. So, is there a reality in Ecuador too? The same slides. Regarding rare disease in Ecuador, there is some estimation, statistical estimation about the people, the amount of people who suffer from rare disease. And it is estimated about 1 million of persons, probably a little more than 1 million of persons from Ecuador suffer from rare disease. Next slide. Taking into account some of the points considering to be considered in the expositions, and talking about the legislation and policies, I would like to say that probably this aspect will be explained better and deeper with Dr. Eliecer, I mean, but at least in paper, there is in the national legislation, there is an law, an organic health law that include in a chapter 3A the topic about rare and orphan disease, and at the same time catastrophical. Sometimes they are confused and called the same, but there is a law and there is a chapter regarding to this topic, this big topic, and the main aspects of this law are that they establish the obligation of free and universal health care for people with rare disease, appoints the National Sanitary Authority as responsible for establishing rules and policies in the management of rare disease, and also National Sanitary Authority defines the list of rare disease. In practical terms, the majority of people considers that these laws are inoperant in the practical point of view, but at least in the paper and in the legal frame, there is a law. Regarding to the one of the most difficult topics, talking about rare disease, that are orphan drugs or treatment that are used to treat this kind of disease. There are 13 pharmacological products included in the basic table of medicines of the Ministry of Health until 2019. The majority of them are related with oncology conditions, but at least there are some pharmacological products. Next slides. Regarding to the research and regulatory police in rabies disorders, is there a frame? Is there a frame? Because observational health research using human biological samples are possible. Must have to be approval to the National Directory of Health Intelligence from the Ministry of Public Health with the previous approval of a human research ethics committee that the health minister recognizes. So there is a frame, but in the practical, in the practical point of view, there is not too easy to face this mechanism, but at least the mechanism to do a research regarding to rabies and even to use human biological samples are possible. Next slide. Another click, please. Yes. Talking about current national activities and areas of emphasis, I think, at least in my opinion, in my point of view, in the last years, we have seen an improvement in this kind of activities, such as conference, congress regarding to rare disease. At the same time, I have seen in the last years a growing in the role of patient advocacy groups. There are many of patient advocacy groups, and I think there are an important partners in this initiative. Next slide. Next slide, please.
Now I'll try it again here.
The next, please.
Yeah. Oops. There we go.
Okay, I think that this is an area of emphasis because this area is talking about the resource, the human resource, especially in the genetics fields and the diagnosis ability situation in Ecuador regarding genetics possibilities, because most of the rare diseases are due by genetic conditions. So this is an area of emphasis because the situation is not so good. There are many areas, many provinces around Ecuador that lack from clinical geneticists or laboratories with genetics tests or genetics support. There are only 4 hospitals in the public health system that offers clinical genetic service with some kind of support in the laboratory, especially with the conventional cytogenetics and a limited number of molecular and biochemical tests. And also there are some private centers located in the 3 most important cities from Ecuador that also has some possibilities to face the genetics diagnosis and the genetics support in the lab. And in the country has around 27 geneticists and 13 genetic advisors, but most of them are not implied in the public health systems. Another, yes. Regarding to the strengths, challenges, barriers, or obstacles in the rare disease, I think that there is not a good balance, in my opinion. But I think even that, there are some strengths. For example, in Ecuador, there are some scientific groups related directly or indirectly with rare disease or with rare disorders. This is the case of Ecuadorian Society of Human Genetics. The National Genetics Program is a program from the health minister from Ecuador who face the development of genetics fields regarding assistance, regarding probably education resource. But I think that there are some barriers or obstacles or challenges. For example, there are no specialized clinics dedicated to treat rare disorders that could be source of researching. There is a little link or joint between academic and assistance health department to define together the priority lines in rare disorders. There is a lack of data on care and diagnostic resource and the epidemiology of the rare disease. I think this is another of the barriers or obstacles. At the same time, I referred before, the advanced genetic and diagnostic techniques in Ecuador are so limited to face the challenge of diagnose rare disorders, and training programs and availability of multidisciplinary team or equipment are not enough, I think, to assume the challenges of diagnosis of rare disorders. Next slides. In these slides, I express my point of view from my situation in a specific genetic service, public genetic service, in which we have identified at least 3 groups of rare pathologies, in which we have a data, a cohort of at least 50 or 70 patients with neuromuscular disorders, sexual development disorders, and movement disorders without a definite genetic diagnosis. I think probably another participants can talk later, but there are another conditions that are recognized to be or to have a higher frequency probably in Ecuador. But I think at least in my service, we have this kind of disorders identified because we have some patients or some, we have data from many patients and family who suffer from this kind of disorders. I think probably it is an opportunity for future collaboration. Thank you very much.
Yeah, thank you very much, Arrianne. I think we'll hold questions until we receive the patient perspective on this. And
Gabriela has a question.
Or did someone have a question? I'm sorry.
Yeah.
No, I was just clapping. Sorry. But thank you again. That was great. Very informative.
Thank you, Gabriela. So is Maritza, will you be making the next presentation?
It's okay.
Okay. I'll have Manuel share the screen with you.
Let me check if I can find the slides. How is the name of the slides?
Because that would be it there. They could be it.
I was not ready to share the slides, sorry.
Yeah, there are 2 sets that came in, so either one would be okay because one included both a Spanish and an English translation. So why don't we can just, are these okay here, Maritza?
Okay, Eliecer will do the presentation in Spanish, and if you need any explanation, please let me know. Eliecer, can you please begin? He is the president in FEPEL Dasha, and I am working with them like a human rights activist. Eliecer, welcome. Adelante.
Ok. Si
Eliecer,
me
¿estás
pasan
ahí?
si me pasan, por favor, la siguiente. Quiero compartir. Ok, la siguiente. Bueno, el estado de la legislación y las políticas existentes en el país. La Constitución nuestra desde el 2008 contiene 444 artículos, 77 de estos son pro vida. Esta Constitución se la denomina una de las más garantistas que en los últimos años ha existido porque da derechos hasta la misma naturaleza. En base a esta Constitución, hemos presentado como fue la foto inicial en la cual estamos entregando el proyecto de ley en el año 2011 ante la Asamblea Nacional para que sea elevada o sea considerada como una ley. Es así que nosotros llegamos a tener el 24 de enero del 2012 esta ley como una herramienta para el tratamiento de las enfermedades raras, huérfanas y catastróficas. Siguiente. El cumplimiento de esta ley realmente ha quedado en el cajón del olvido durante estos últimos 9 años, ya que se consideraba la publicación de un listado de enfermedades, que la Organización Mundial de la Salud y tiene como tal. Sin embargo, tanto los protocolos y este listado no han sido hasta el momento expuestos. Esta situación ha hecho que seamos invisibilizados en el país, ya que políticamente solo se ha trabajado por otros grupos y hemos tenido que hacer defensa de derechos para conseguir su medicación. Solamente en el Ecuador es la que se encuentra dentro de un cuadro básico de medicamentos. Fuera de ello, tenemos que demandar al Estado para que podamos medicar a nuestros pacientes. Tal es así que en el tamizaje neonatal de las 8,000 enfermedades, obviamente sabemos que apenas en los países más desarrollados están por 150 enfermedades. Ecuador viene realizando el tamizaje neonatal desde el 2012 apenas para 4 enfermedades. No hemos podido, no ha tenido el Estado la capacidad de por lo menos aumentar en un principio lo que pensamos llegar por lo menos a unas 36 enfermedades. Bueno, ante todo esto, en la actualidad que estamos con una nueva fase política, con un nuevo mandatario, un próximo gobernante que se va a posesionar el 24 de mayo de este año. En su campaña política hemos podido ser parte de sus lineamientos y es como hemos buscado tener un compromiso con el vicepresidente que hoy ya electo entrará en funciones y está afincado ahí nuestras esperanzas para que estas políticas sean posibles. Próxima. La próxima, por favor. Los desafíos y barreras que tenemos por enfrentar en el Ecuador. Primeramente, socializar y empoderarnos de todo lo que significa el quehacer por las enfermedades raras. Como decía en un principio, se ha trabajado solamente por un grupo social y muchas de las enfermedades raras son vistas de esta manera, solo como enfermedades catastróficas o como discapacidades. Nuestra gran tarea es
Eliecer, ¿se te fue el audio?
We lost the audio.
Ok, es el internet, mil perdones, es internet por el efecto climático que tenemos.
Quita la imagen, Eliecer. Probablemente así tengas más canal para transmitir.
Creo que ahí regresé nuevamente. Es problema de señal. Bueno, otro de los retos que tenemos es ser parte de los organismos internacionales y tomadores de decisiones por las enfermedades raras, tanto a nivel nacional e internacionalmente, como ya venimos realizando. Que se inicie un plan nacional de concientización contra el discrimen, la apatía social, que permitan el uso de los espacios en medios de comunicación para programas informativos y educativos que no tenemos, insisto, a no ser solamente como discapacidades. Es decir, en el Ecuador los pacientes tienen que atravesar todo este olvido sin diagnóstico para llegar a una discapacidad. Es el momento cuando recién tienen derechos, ya que ahí se permite un carnet de discapacidad, lo cual es una situación terrible. La siguiente, por favor. La siguiente. La siguiente lámina, por favor.
Eliecer, ¿no estás viendo mi lámina? Estamos en necesidades legislativas o políticas.
Mari, estoy cortado con la señal del internet por fuerte lluvia. ¿Me puedes seguir, por favor? ¿Puedes seguir tú que estás
Ok, listo.
Has de saber que mil perdones que tenemos ese problema.
Okay, sorry, but Eliecer have problems with his internet, so we'll do the next slides. The 67 law is reviewed by scientific and medical personnel, but not only by lawyers with political calculation or with high economic cost. That means that we need an interdisciplinary team for review the laws in Ecuador. On the other hand, the terms that we use in Ecuador are ambiguous. For example, is confused the definition with rare disease with catastrophic disease, for example. And also we need penalties for people that delayed or can be can be lost the time of the patients. Okay, future collaboration opportunities. We are looking for different organs, such as people's defenders with a joint work that seeks to live the established model. We are fighting because the rights of the patients can be warranted in short time, not waiting the schedule for 2020, 2030 objectives. The other opportunity is to create new agencies for defense of the rights of the rare disease patients. Finally, about suggested activities for the country, suggested and sustainable activities for the country. We consider that the relators in international organizations like United Nations, OPS, WHO, come out of their convenience and they can visit the affected population, not only the authorities. Also, that this topic can be treated between the states, creating regional policies to have chances of care at lower cost. That Genomic Medicine Institute project, it's a form of research in this field, and is a project that we are presenting with Dr. Milton Gijon in actual government. And we need incentive for national and international research. That's all. Talking about primary prevention, endogamia, and consanguinity, it is our commitment. Thank you very much.
Okay, thank you all very much, Manuel. I'll just turn it over to you. Dr. Milton, are you going to make a few comments or?
There is no comments. We can.
No comments? Okay.
No.
I think one of the questions that was raised, Ecuador, like the United States, has recently had a new government installed into operation. Have you had any feedback from the new government officials as far as their willingness to work with the organizations to emphasize rare diseases even more? Any changes that you've noticed?
Sorry, the audio is not good. Can you repeat, please?
Yes, what is the expectation with regard to the new government in Ecuador and rare diseases?
Okay. About the new government, we have the expectation now with Guillermo Lasso because the vice president signed one agreement with Funedere and FEPELDASHA and other organizations. And we are now waiting that this promise for Genomic Medicine Institute can be a reality. I don't know if Dr. Milton Gijon can you say something more about the actual government expectation?
In any case, the government is not really formed, because I understood from Eliecer that the government will take their new position in May, 24th of May, no? Is that correct?
Yes, it's correct.
You are expecting for this new government and to see the vice president achieve their commitment with you, no? With the rare diseases, not with you personally, but with rare diseases.
With rare diseases, yes, the agreement was signed with the organizations that represent rare diseases patients.
Okay, thank you.
Yo tengo una pregunta, tal vez también un comentario. Perdí la señal por un momento y no oí la definición de enfermedad rara o enfermedad huérfana, o cómo la llaman allá. En Colombia les contamos que se decidió en la ley utilizar el término de enfermedad huérfana, lo cual llevó a mucha confusión. Y veo por la última intervención que en Ecuador tienen algo parecido, porque se habla de las enfermedades crónicamente debilitantes, y eso es tal cual aparecía en la ley colombiana. En la ley colombiana, la definición son las de la prevalencia menor de 1 en 5.000 personas. ¿Cómo quedó en Ecuador? Allá se había propuesto que fuera como la europea, menor a 1 en 2.000 personas. Esa es la primera pregunta. Después le hago otra pregunta.
Sí, Luis, ese justamente es uno de los inconvenientes que tenemos acá en Ecuador, porque digamos que se confunde. La ley 67 justamente está hecha para enfermedades raras, huérfanas o poco frecuentes. No, mentiras, comienza con enfermedades catastróficas, raras, huérfanas o poco frecuentes. Entonces, los fondos públicos se destinan, digamos, para enfermedades catastróficas como cáncer, SIDA, pero las enfermedades raras se quedan, digamos, de lado, en el sentido de que no se asignan recursos para los pacientes o para los medicamentos huérfanos que se necesitan para el tratamiento de estos pacientes. No sé si el doctor Milton Gijón nos puede apoyar un poco en esta inquietud.
I think Dr. Acosta has...
Hello, everybody. Can you listen to me?
Yes.
Sí, sí, estamos oyendo.
In Ecuador, we have a concept for rare disease. If you have 2 patients by 10,000 people, that's the concept. And it's Ecuador.
Which means 1 in 5,000.
1 in 5,000, it's okay. It's the same concept.
Okay, and the other thing is in the same law, rare, neglected, and some other diseases, or
low frequency.
I didn't understand well, because in the way it was stated, I understood that the law was also for some other diseases, and not only for rare diseases.
I would like to say something about that, because in Ecuador, we have many laws, but neither of them is applied in correct way. So the next government have a great challenge, because until today, the rare disease are not attended, or they don't have really attention. So we are expecting that the new government, even because the vice president-elect is a medical doctor, is a neurosurgeon, so we have signed an agreement with him. Even the next government have the obligation to build the Institute of Genetics Medicine. The Institute of Genetics Medicine, it's a goal, it's a challenge. So the million people that we estimate as affected with a rare disease, we are very hopefully, especially to have attention with medicines, with the clinical attention, with integral attention that until today we don't have. So for the Ecuador, the next government is have a great expectative.
What happened with the lysosomal storage diseases? Usually they are the ones that open the path. In other words, in Colombia, the lysosomal storage disease treatment came before the treatment for any other rare diseases. Are you paying the enzyme replacement therapy, say for Horler, Hunter, Gaucher, Fabry?
In Ecuador, the laws estimate in generally circumstances for all disease. We don't have any law for a special or unique disease. So in any case, the laws in Ecuador are right, but not in the practical, it's applied.
Also,
Okay.
sorry, I just wanted to mention that even though the law says that it should be free for everyone, it's not. And what Eliecer was talking about is that sometimes they have to sue the government, so the government pays the drug. So that's how you have, I mean, in a normal way, you don't get it. You have to sue the government, and then when the news get, and it's a big deal, then the drug gets paid.
I think Dr.
Yes, I wanted to make a comment. It means I live in Washington, D.C., and I just had the opportunity to meet somebody some time ago that was lobbying at the UN about rare diseases. She was a lawyer that has children from Latin America with rare diseases. I don't remember exactly the country. If I am wrong, I don't remember the country. But she was very successful lobbying it at the UN, and actually that was in 2018, and that was at the time that the UN created the committee for the rare diseases. And I have a very interesting conversation with her because basically she was not a physician, she was a lawyer. And her approach was basically, and I wanted to share with all of you this experience because for me as a physician was very interesting how people that is not a physician understand and look at different perspectives the situation. It means that what she was trying to convince the UN was about that rare diseases should be looked as a human right, like LGBT rights or race or anything, because basically if you don't give the opportunity to patients with rare disease to be treated, you are depriving of the right to live. And I really, what I understood is that she was part of a committee that was very successful creating the concern of that. I mean that basically after that, the UN created a committee that if you go look at the UN website, you can see that there is a specific committee for the rare diseases that has a lot of things to do, and they created a lot of momentum at that time that has been working. But my point is, like, I really feel that this group can capitalize in the big organizations without focusing in what is the particular definition of the number 1 in 5,000 or 1 in 2,000, but really as a big, what is rare diseases and how it can be moved forward. I really love the presentation today, because basically is more towards what is the legislation and how we as a group can push, like in the different governments, to push as a definition of rare diseases. Doesn't matter that in one country is 1 in 5,000 and the other is in 1 in 4,000. Every country maybe have a different definition, but basically that it needs to be a legislation that cover the patients that need to be legally covered by the right to be attended and receive treatment and interventions, even if you need to sue the government for those treatments. Yes, but it's a point where you need to start to fight, and as a group, it would be probably to be supported and maybe go to these big organizations that can support. I know the UN has a very strong group here in DC, in Washington, and there are other or local organizations, but I know the people here in UN that are working. It means I just think that as a group, maybe reaching the local representative of these organizations that can congregate the different countries could be a starting point to pressure the governments to some type of legislation that could be the starting point to have a legislation that is common to the different countries, and then we can define what could be covered or what can not cover, depends on the specific disease.
Okay, thank you.
Manuel, go ahead, please.
No. Just to say that we need to continue, because we spent a lot of time with the discussion. It is too late for us.
Gabriela Repetto from Chile will transfer it over to you. Can you accept this sharing of the screen?
Okay, so thank you, everybody, for being here, and thank you, Stephen, for the invitation to present about Chile. I think because of the time, as Manuela and probably Domenica, if she's still here with us, I think I would like to suggest that the patient organizations present first, and then if we have time, I can fill in with some sort of data and numbers, or otherwise I can send that information to you in writing. But I think that I think what we need to hear more frequent from the patients, and we have the luxury of having here with us the leaders and members of the three main umbrella patient organizations in Chile, who have put this presentation together. So if that's okay with everybody, I think I'd like to turn over the screen to them.
Okay.
Cecilia is making the presentation, I believe.
Yes. So you share a screen?
I don't know if you have.
Or if it's easier, I can share the.
Cecilia. Let me check, see if I can see. Is this your presentation?
Yes.
Yes.
Thank you very much. First, thank you very much for the opportunity to share some patients' thoughts. As Dr. Repetto was saying, I am very, very pleased I'm only the spokeswoman for 3 patients organizations that are umbrella patients organizations. So we have here Alejandro Andrade from FECHER, Gonzalo Tovar from Alianza de Pacientes, and Jessica Cubillos from FEMPOF. This is a work that we have done all together. So the next slide, please. We want to share with you three three big issues. As patients, we in these days, we want to focus in three main issues. One is the, sorry?
No, you can continue.
One is the, okay, sorry. One is the experience of living with a rare disease. In Chile, we use three terms. Last year, a law was approved to celebrate the National Day. I'm going to refer to that a little further, but to clarify the names that are being used in Chile, we are using enfermedad rara, enfermedad poco frecuente, and enfermedad huérfana. Rare disease, low prevalence disease, and orphan disease. Both are being used, the three of them, sorry, are being used in Chile. So the experience of living with a rare disease in Chile, when we speak about public policies, what we have gained and what are the gaps, and also about access and coverage in therapies, especially in high-cost therapies. The next one, please. So about the experience of living with a rare disease in Chile, there are also three issues that we want to address. The first is the access to diagnose, the cost of living with this disease, and all the aspects of the illness, social effects, and emotional effects and other effects. We like to speak about this difference between illness and disease. And disease are not being addressed very well, but illness is not being addressed also. The next, please. So about diagnosis, some numbers. FECHER, they did a work with interviewing many patients with rare diseases. So we have some numbers of their work, and 47% of the cases are being diagnosed before 3 years. But the most common is that people, they are taking between 7 and 12 years to have a diagnosis. And 7 from 10 patients needs to confirm their diagnosis with a genetic exam. So those are about the diagnosis. The next, please. When we speak about how much it costs, in Chile, a family, they have a salary about 400,000 pesos. No, 400,000 pesos. I am confused with thousands and hundreds. 400,000 pesos. Okay, yeah. That's what a medium family earns. But what you need to expend when you have a rare disease is more than 1 million. So you need to expend 2.8 times your salary only in your disease. And we have a mixed health system, the public FONASA system and the private ISAPRE system. And 76% of the population with rare disease do not have any coverage for what they need for their diseases, not even if they are in FONASA or in ISAPRE. Public and private have the same problem. That about cost. The next, please. When we speak about illness, social effects and emotional effects, 8 from 10 people have abandoned their life plans, their dreams. 3 in 10 do not have energy to make new plans. They don't want to make any new plans. 6 in 10 have been discriminated. 6 in 10 have seen how their house economy has been very affected. And 51% are mothers or daughters of people living with a rare disease. So what we feel about this, as many of the countries, we have a very huge gap in addressing the disease, but we are not addressing the illness. All what comes with the disease, we are not addressing it either. And many times they're high cost, for example, for therapies, for new medication, but it's not so high cost addressing the other effects of the disease, but it's not being addressed either. And there is where the patients' organization play a very special role, because patients' organizations are giving support in these other issues to the families and to the patients. But also patients' organizations are not receiving funding. So this is a volunteer work that really needs a lot of energy, a lot of time, of dedication. The next one, please. In public policies, some things that have been addressed. What's good, what we say, okay, we did it, or other people did it. We have a national day so that we can educate population in what a rare disease means, what rare diseases are. We also have now, this year, the government is working on a decade plan, and rare diseases have been included in that plan. We don't know yet in what way they have been included, because they are starting to make this plan, but rare diseases for the first time will be included in the national goals, health goals for the decade. Also, at this point, I will just mention it because Dr. Repetto will address it more deeply. We have been working in different collaborative working groups to make a national plan in rare diseases. It will be presented this week, but it needs political support, and the government this year, we are having elections. So we don't know if that plan will start soon or is something that we will need to address with the next government. And also something very important for the patients group is that we have been working in a collaborative working group in APEC to have ethical guidance for the patients group. So patients group can be funded, but also can work more secure with different stakeholders. And can manage the conflict of interest. The next one, please. In public policies, what are the gaps? What we are missing? The Ministry of Health still doesn't have a structure, a regular formal structure with somebody or a department in charge of rare diseases, and that's something we think to have a plan, to have objectives for the decade needs to have somebody in charge. Nobody's in charge yet. We don't know if we need a law or a different kind of regulation that can guarantee access and the right to all the patients with rare diseases to have their diagnosis, attention, and coverage. So we are exploring which is the best way. Does the plan need a law? That are questions that are in this time on the table. And also what is still a gap is that we have many pilots. I don't know if that's the right word in English. When you try something to see if it works, we have been trying some things for many, many years. So it's time to, okay, if that is working, we should have a program. Stop piloting. Let's make it a program. So in that way, we think it would be having a screening will allow to have many people with earlier diagnosis. So it would be something important to advance. The next one, about coverage in medications, we have some advances. We have a law that it's called Repetto Soto, that it gives coverage to high-cost medication. Nowadays, it covers 27 health problems, but only 16 or 17 of them are rare diseases. And this law, it generated some problems with expectatives, because it started, two things got mixed. High drug, a law to give coverage to high cost drugs, but also there was a law for rare diseases, and they put both together and made one. But it's not that. It's not a law for rare diseases. It's a law for high price drugs. So we think it's very important to make the difference. Even though it works for these 27 health problems, it works, but it needs to make the difference in that. We also think that we need to work as a country when we get to make decisions about which drugs are going to be covered by the system. We don't have an agreement on which is the way new technologies are going to be evaluated. And we think that is something very important to have soon in the country. And also, we think that when we speak about therapies, for example, biological treatments that are very needed for many of these diseases, it's not only about coverage, because, okay, you give coverage to a medication, but if people don't have access to doctors, to exams, to diagnosis, it doesn't matter that coverage, that your drug is paid, if you don't have access to all the other complements that are not complements, that are basics. So that's the problem with these drugs. This law that only takes charge, that only afford the price of the drugs, but know how people can get to have all the steps needed to get and to have that drug. And also for the patients, and especially for the patients' organizations, this is a process of a high stress, because as nobody knows, we don't have this agreement on how the decisions are made. It's a very stressful process, because you need to do a lot of advocacy to get your medication of your disease covered. We think that this should be a process much more in harmony for everybody. And the next one, I think the next one is just the last one, and it's more to share some thoughts, that it's not very different what a patient in Chile and his family is living. But we have some particular aspects of what a person in Chile lives. And even though we are living a lack of access, lack of diagnosis and treatment, and even though we think that the system is not fair and it may feel very distant and not very engaged to patient needs, we still have the strength to keep pushing for a change. And that's what we wanted to share from the patient's perspective.
Thank you very much. May I comment a little bit? Thank you, Cecilia. It has been very, very interesting to me, your presentation. And I was really interested in the distinction that you made between disease, illness, so the different aspects. And then I'm asking about the sickness, about the perception, the social perception of the disease in your society, because you made a clear distinction between diseases, which are the medical, let's say, definition, the illness, which is the personal perception, and then the social perception. So, how is the social perception? Maybe
Sorry.
Yeah.
Sí, I just want to say that si alguien más de los líderes que están me están preguntando por la percepción social de las enfermedades raras en Chile. Si quieren agregar algo, lo ponen en el chat y lo voy comentando. Siéntanse como libres, porfa, de complementar. We still have a lot of, we haven't agreed in this definition, but I believe that we still have a lot of stigma to rare diseases. Like stigma to what's unknown.
Thank you. Yeah. Thank you. This is good enough for me. Thank you. We can go further later on. Not today.
Please. Sorry,
Yes.
I want to say something.
Espera, Claudia, espera, que está hablando Dr. Milton. Dr. Milton, go ahead.
Oh, thank you. I'm very grateful for the invitation to this meeting. I need to say a few words about the situation in Ecuador. In Ecuador, we have a really challenge with a rare disease. The attention are poor and difficult, especially to get medication and treatment in several forms. The last 14 years, the patients with rare disease were forgotten for the government. The health public policies does not include the rare disease. Until today, we don't have in Ecuador any plan or system to attend the rare disease. So with the next government, Funedere and other foundations of rare disease, we have signed a document with the vice president with the mean that they be able to do the Medicine Genetic Institute. So for us in Ecuador, the expectative for immediately times are very great. And we need some international cooperation for this, to get this challenge. I am Dr. Milton Gijon. I am geneticist, and I attend clinical genetics in Ecuador for the last 30 years. Thank you very much.
Thank you, Dr. Milton. Claudia, do you have some comments?
Thank you very much.
Yeah, I just had a quick question from Cecilia's presentation about where you said that 7 out of 10 patients have a genetic diagnosis. Does that mean that like they have a suspected genetic disease, or that they actually are getting a genetic molecular diagnosis for the disease?
Alejandro, ¿estás por ahí? Es la pregunta sobre los 7 de 10 pacientes confirman su diagnóstico con un examen genético. ¿Es que efectivamente tienen acceso a un examen genético?
En efecto, ellos sí acceden a un examen genético molecular.
Oh, okay. So that's great, because then that means about like 70% of your patients will have a confirmed molecular diagnosis.
But
Can I chime into that?
Yeah, porque no, o sea, no acceden, no es que accedan rápida, they don't access, it's not a early process. It's about what we were mentioning about the 10, 12 years. Pero eso, Gabriela, sí, yo ese te lo dejo.
Finally, they have the diagnosis with a molecular exam, but that don't be in the first years for this suspicious. It's only in the end of this way, 12 years ago. But the only way we have the only way we have to make some diagnosis is with a molecular exam.
Gabriela, do you want to add something? Maybe
Yes,
you can introduce your presentation too.
Yeah, maybe have Gabriela go ahead and then we will end it after Gabriela's.
Yeah, or if you prefer to continue the discussion, or I can quickly show my slides. I can share them from the screen. Just to that particular question, I think first thank Cecilia, Alejandro, and Jessica who put this presentation together and speaking on behalf of very many patients. I think it's great work that they're doing together in cooperation, because I think that has been sort of pushing the needle in Chile over the last couple of years. Regarding molecular testing specifically, it's not, very few tests are covered in Chile. So it's karyotype and MLPA and FISH and just limited Sanger sequencing and some metabolic testing. The data, I think it's for persons who have already reached the diagnosis and paid for it out of pocket themselves. And I'll show you some figures about that, because the reality is that this testing is not covered and there's very little availability in Chile at that point. So what happens sometimes is that we're seeing sort of the tip of the iceberg of people who really were able to reach a diagnosis beyond the clinical evaluation, and we're able to pay out of pocket for a test, which is definitely something that we need to improve. So I'm just going to go quickly over some of these slides, because I know Cecilia very thoroughly described them as I hear in my first slide, I'm a clinical geneticist working in Santiago, and I just sort of put a little bit of geographic information and perspective here. But Chile has a population of about almost 20 million. So we have similar figures as Arrianne presented earlier. So we estimate about 1 million persons with a rare disease. As in many Latin American countries, the majority of us live in Santiago. Almost half of the population lives here in the center of the country. In terms of economic, averages always look great, and the GDP per capita is over $20,000, which puts us in the high income countries. But when you look, and this is something that Cecilia mentioned, at the distribution of income and medium income, it's substantially low. So the 400,000 pesos a month that Cecilia mentioned are about $6,000 per year of medium household income. We have about 9% of our GDP is spent in health, which is about $1,500 per capita per year, which is probably the highest in Latin America. But as Cecilia also mentioned, and I just described regarding genetic test, we are one of the countries with the highest out-of-pocket expenses in health, and about a third of expenses in average are paid directly by individuals and families. And we have a mixed healthcare system where the majority is public and it's paid out of specific taxes and individual contributions. We have about 15% of us in private healthcare system, which is all personal contributions, and the armed forces have their own system. And one of the things that is very paradoxical about Chile considering our income per capita and the number of scientists in the country, we are one of the countries in the OECD countries that has the least R&D expenditure, both in percentages and in absolute amounts. And we think that this is one of the many areas that also impact the care of or insufficient care of persons with rare diseases. This is something that Cecilia already mentioned about what are the policies that are currently available. We have universal newborn screening for PKU and hypothyroidism since the 1990s. There's been a pilot for the last couple of years for other 20 inborn errors of metabolism, cystic fibrosis, and hearing loss. Sorry, I skipped an S there. But unfortunately, the reason was the pandemic, but we don't know if that's the real reason, but this was suspended in late 2019. And as Cecilia said, we need to start moving from a pilot that has already proved its value to a real program. We have healthcare reform that happened 15 years ago. That's called the Explicit Health Guarantees Laws. And the framework for this law is based on population burden of disease. So this covers mostly common diseases, but there are three rare diseases that were included here. And this is mostly due to really patient associations lobbying and their strong voices that helped include them there. And they are the hemophilia, cystic fibrosis, and cancer in children. Cecilia already talked about the high cost medication devices law that covers some rare diseases. And as she also mentioned, as of late 2020, we have a National Rare Diseases Awareness and Education Day. And again, this is another conquest that was really pushed forward by the Patient Association in with the assistance of two legislators. I'm going to skip over this one, which is about the rare diseases, the Ley Regate Soto, the high cost medication, just to say that, again, to reinforce the point that Cecilia made, that this was understood to be a rare diseases law, but in reality is not. It's a high cost and medication and device law. It does not cover diagnosis. It does not cover comprehensive therapies. So again, it's definitely a plus for the patients who can have access, but there are substantial gaps, and the process is very peculiar. There's a lot of citizen participation in the process, but there's also built in a competitive way. So patients are really competing to get their needs addressed by this law instead of there being sort of a more equilibrated framework. As of 2020, I think the whole country really was invited to help in the development of a national plan for rare diseases. This is work that was promoted by Senator Carolina Goich and the Ministry of Health. And as Cecilia described, we are having weekly multi-stakeholder meetings to build this plan. There are over 150 persons that have collaborated in this. And we are divided in 5 major themes, one on education and awareness, one on registries and research, governance and organization, clinical services, and financial protection. And we're due to deliver our first draft to the Ministry of Health this Friday. So we'll let you know in our next meeting how that goes. And Cecilia also mentioned this, that there was explicit commit announcement by the Ministry of Health last week to include rare diseases for the first time in the Chilean health goal plans for the next decade. What are some of the challenges? I think that these are things that are in common. We have a lack of local definition of rare diseases, whether it's going to be a prevalence and complexity or in lack of treatment. This is something that these working groups are addressing. Another point, I think, is that, as you know, in clinical practice, good therapy requires good diagnosis. And this is not only on a personal level, but also on a societal level. And we still lack information on how many patients there are, what diseases they have, what their illnesses and trajectories and the systems are, what their needs. So we need really to collect more information to really make plans that make sense. But we have the sense again that we have many immediate needs, but many of these gaps we need to be aware that are going to take a long time to fill, and we need to sit down and really establish priorities. And we also need consensus in several areas. One of them again is the name and the definition, but also we've had very interesting discussions about how I think there's agreement that there needs to be a specific funding mechanism for rare diseases, but again, whether it's a separate fund like the Ley Ricardo Soto with all its goods and bads versus a more integration into the general system with the expectation that Chile will reach universal health coverage. I think that's one of the debates. Another debate that has come up in these working groups, whether we need a centralized national institute versus really an integrated system that can take care of our vast geographic dispersion. And also, even if we have whether a national institute or centers of excellence per regions in Chile, who sets quality standards? What are these quality standards? I think one of the things that happens frequently here in Latin America is that we have self-declared centers of excellence or appointed centers of excellence without really clarifying what a center of excellence has to deliver and be considered as and what are the again, what are the expectations and the deliverables? Again, I think all our working group documents, I think are going to move forward in this direction of establishing a healthcare needs and legislation. So hopefully again, throughout this year, we hope to be able to give you more information how that process goes. But I think that in addition, another substantial gain that we observed actually about a month ago is that for the first time, we had the explicit inclusion of the need for research in rare diseases, biobanks and policies and data sharing that also impact persons with rare diseases in the last request for funding applications of our Ministry of Science. I've been on this over 25 years, and this is the first time that I see rare diseases written on a government RFA for research. We also have some concerns about the impact of private data privacy laws that are being developed right now. They have a lot of focus on banking and financial aspects, but we have a sense that they may spill over research and data sharing for other purposes. So that's a concern. And the other thing I think it's been a good thing that has happened is the role of telehealth moved by the COVID pandemic that has hit Chile, well, like every other country, really, really badly. But this is also, I think, contributing majorly to access to also to have regulations there, and increasing those services and doing it in a better way, I think would definitely be a benefit. And just my last two slides, I joined these about future collaborations and regional collaborations. I think I am aware that there's a lot of information out there on rare diseases, but I think that ERCAL could be a repository, which is what you've been doing already, an analysis of the programs and the legislations in Latin American country, but not just gathering the information, but having some critical assessments of what has worked at the implementation level. We just heard from Ecuador, you have a law, you know, I was just very jealous of your description of very forward-thinking constitution, but that really needs to be paired with day-to-day implementation. So I think learning from doing those analysis and learning from other countries, I think it's something that ERCAL can do. I think it's also useful that we can all connect and work on best practices in our regional context. I think a lot of us have access to papers and great guidelines, but a lot of that, and that may even be translated, but some of them may not really be applicable for different reasons. So I think this is something that we could work on as a group. Also share our education educational activities and share resources. I think one specific area is genomic testing. And I know we heard 2 weeks ago from Roberto Giuliani in Brazil, and they're doing really a great job. But I think we need to work on how that can sort of spill over to the rest of the region. And again, become a repository of educational materials in language and in context for our families and patients. And I think this is my last slide. I'm just taking advantage of this podium here, but this is an announcement and an invitation from a sister organization to ERIC. This is something that we could also participate in, which is the Global Genomic Medicine Collaborative, which is an international group that several of us work in. I see Claudia here and Jürgen that stepped out. But we're working on genomic medicine implementation in low and middle income countries, such as ours. Again, even though Chile is considered a high income country, it is low income in terms of genomic and rare disease development. And we'll have a virtual meeting at the end of September. And right now we are open for abstracts, presentations from young investigators and young clinicians from the region. And I think that, I don't know what Claudia thinks, but I think this could also be open to patient organizations to present their work at the meeting. So, so the website is g2mc.org, and then you can move through the website to find the meeting and the abstract submission. So I think that was my last slide. And I had my hand raised all the time. I just saw that, sorry.
Great, thank you very much, Gabriela. I'd like to thank all of the presenters tonight. We will feature the recording of the presentations as well as the slides for everyone to view later on the ERCAL website through iCord. So I think most of you received the links that you can check. I don't know if there's time for questions or not. We're running rather late. I just want to mention that on May 11th, we will have presentations from Peru and Bolivia. And we have several speakers lined up, but please visit the information on the website and what I sent out. And if you have suggestions for any of the other countries that we don't have speakers, please share them with us as soon as possible so we can try to connect with them as we go forward. Is there a burning question or a question that would like to be asked quickly before we terminate the evening here?
Well, I don't have a burning questions. I would like really to thank all speakers because I enjoyed very much the presentation, the session this evening. So it's really interesting and stimulating. So thank you very much to Steve for organizing everything and for the speakers for presenting the slides and the activities. Thank you so much.
Okay.
I would also like to agree with Domenica in thanking everyone and Steve for organizing the meeting and Manuel for coordinating the session. Thank you very much to all of you.
Yeah, thanks to Luis also. Yeah, thank you to you.
Okay, so I think we'll end it with that, and I look forward then to having you join us on May 11th as we move into a new month. So thank you and good night or good morning, depending if Jürgen has joined us or wherever you are.
Thank you.
Thank you all very much.
Yeah,
Bye-bye.
thank you for the invitation.
Thank
and we
you.
hope that
Thank
we
you.
stay connected.
Good luck.
you very
Good luck
much.
for your
Bye-bye.
good luck in Chile for your for the presentation or your law. Yeah, congratulations.
Thank you.
Let us know.
We will. Yeah, have to invite us for part 2.
Yes.